I'd like to thank the organizers at the Sanibel meeting for allowing me to do this, as well as Grifols for sponsoring me to do this. And I give you guys credit. It's gorgeous outside. And you got to have the gumption to come in here when it's the way it is out there. For any of you who don't know who I am, my name is Greg Mork. Currently, my role is Director of Clinical Perfusion at Rush University Medical Center. And previous to that, I worked at University of Illinois Medical Center, and I was a Director of Clinical Perfusion at that location as well. And over the years, I've been involved with a lot of organizations, most recently AMSEC, and I really enjoy what I do. And I enjoy having the opportunity to talk to yourselves, students that are here. I'm one of the clinical instructors for the Rush program, and I really enjoy having them around. And having said that, I'd like to get started. Hereditary antithrombin deficiency. Us as perfusionists, how do we figure this stuff out? How do we? And I would be surprised if a good significant number of patient or perfusionists in this room. As a matter of fact, if I could see a show of hands, how many people have had the occurrence where they've heparinized and not gotten the ACT to go up, and heparinized again and not gotten it to go up? Can you put your hands up? See, it's probably 70% of the people in here. So it's a real issue, and it's something that we have to deal with and address when it arrives, it shows up. So what are we going to talk about? Role of AT in coagulation, AT deficiency and thrombotic risk, hereditary antithrombin deficiency, how to diagnose it, and the risk of VTE during pregnancy. Some very interesting data that supports some of the risks that pregnant women have at certain periods of their pregnancy. Risk of VTE in a surgical setting, which is the place that we're at. And the nice thing about this talk is there's some slides in the middle that have a little bit data heavy, but at the end of the presentation, there's 2 case studies. And those 2 case studies really wrap things up really well and really lay things out in black and white of what it is, what a hereditary antithrombin deficiency looks like when it's recognized, when it's not recognized, and such. It's not as rare as you think. It affects 1 in 500 to 5,000 healthy individuals in the United States. And that's roughly comes out to about 67,000 to 656,000 people in the United States. Prevalence of VTE patients, up to 3% end up with VTEs. 16,500 patients a year end up with, are diagnosed with this annually, and 5.4% of the women with thromboses during pregnancy and puerperium. The needs of a patient with hereditary antithrombin deficiency are often discounted. PEs, DVTs, the guidelines suggest that testing or identification for a specific thrombophilia isn't generally necessary when a family history is discovered. Just give direct oral anticoagulants, heparin, warfarin, medical management. None of that stuff will change. Now we find out that that's not necessarily the case. And the other perception is that hereditary antithrombin deficiency is rare. I've never seen a hereditary antithrombin deficiency patient, so testing for hATd isn't necessary. Now we know there's some things wrong with these perceptions. The essential role, and for the new grads or people in school, you'll remember some of these slides that I'm going to show very well. For some of us who have been in the field, it's just like the clotting cascade and Krebs cycle. We kind of remember it, but sometimes we have to go back and refresh it. AT activates multiple clotting factors in the coagulation cascade. And the anticoagulation effects of heparin rely on its interaction with antithrombin. So heparin depends on AT as a cofactor. And heparin is ineffective in the absence or near absence of antithrombin. That's one of the things we see as perfusionists, especially if we give a couple loading doses and we get no response. The important part, the anticoagulant activity of antithrombin is accelerated greater than 1,000 times when bound to administered heparin. So here's a slide that may give some of you a little bit of PTSD. Here's the clotting cascade, the extrinsic and the extrinsic pathway. But you can see all the different areas that antithrombin has an effect on the clotting cascade. So when we have a low antithrombin level, or in this case, hereditary antithrombin deficiency, we're going to have significant issues, and they are multiple. As we all know from some of our schooling, without heparin, AT binds and inhibits factor 10A and thrombin activity less effectively. So on the top, you see the antithrombin without heparin. Once heparin is added, you see in the bottom, it binds everything together. And at that point, our clotting times are extended. And that's when we get our ACTs up to a level that we like, especially in cardiopulmonary surgery. The impact of AT deficiency on heparin action. Reduced concentrations of AT as a cofactor for heparin require increased doses of heparin. Now, the important part for this is some of these patients may be heparin resistant. And what causes that? Well, maybe somebody who's been on long-term dialysis. There could also be heparin resistance, need for higher doses. This may provide a diagnostic clue for antithrombin. AT deficiency may be hereditary, genetic, or acquired, such as trauma, sepsis, or other inflammatory conditions, and mechanical support. That's another scenario where you could deplete your AT3 levels. Sometimes increasing heparin levels without considering the possibility of antithrombin deficiency can have disastrous effects. And we know that if we go on bypass and we don't have an adequate ACT, we are opening ourselves up for a world of hurt at some point in the case. Either it's after the case when the patient never stops bleeding, or during the case when things clot up. The correlation between antithrombin deficiency and thrombotic risk. Now, it's very significant. If you look at all the thrombophilia, on the left, the red bar is hereditary antithrombin deficiency. And now, if you look at all the other thrombophilias, protein C deficiency, protein S deficiency, factor 5, elevated factor 8, prothrombin gene mutation, and I can't even read that word, but those are all the other thrombophilias, and the significance and impact they have on the patients is far less than the risk that hereditary antithrombin deficiency will pose for a patient. As indicated by this slide, you see a normal antithrombin is greater than 100. And one reference, so it's the number of patients that are prone to VTEs are relatively insignificant at that point. However, you drop down to antithrombin 3 levels of 45 to 60. Now all of a sudden you've multiplied the significance or the likelihood that you're going to have an incident 23 times. So it's a very huge significant factor when your AT3 levels are low, even moderately low. So normal is greater than equal to 80%. Mild deficiency, 70 to 80% of normal. Now you're up to 2.8 times likelihood of having an issue. But when you go to an overt deficiency, that means it's under 70% of normal. Now all of a sudden you jump up to 6.8 incident rates per 100 patients. So that's a significant climb. Cumulative thrombotic risk increases with age. By age 35, these are patients that have a diagnosed hereditary antithrombin 3 deficiency. And by age 35, 70% of those patients will have an incident. By age 50, 85% will have one. And then, of course, the last bar on the right, any age, recurrent possibility is 63% incidence with hereditary antithrombin deficiency. So it's a significant risk factor for this disease. How do we diagnose it? First of all, here's a pedigree chart. Remember this from your genetics courses, biology. Odds are, if one of your parents has the gene or the factor, you have a 50% chance of inheriting this factor yourself. So that's why it's important if for some reason any of your family members or somebody you know, or they just randomly have a pulmonary embolism or some kind of VTE or some episode, it becomes really important at that point to go back into the family history. Because the odds are, and it's not all the time, but odds are you're probably going to see somebody else in your family tree that has had this issue. And certainly if you are aware of any of your parents or their parents having this gene or having this factor within their gene, it's certainly worth looking into a little bit further and making sure that you don't have any issues with this further on down the road, especially if you're going to be scheduled for some type of surgery. And each surgery has a different risk factor for how dramatic the deficiency will affect their outcomes. Normal AT levels, as I said, 80 to 120%. Mild AT, antithrombin deficiency, 70 to 80% of normal. And now all of a sudden you've got a 2.4-fold increase in the possibility of you having a issue or VTE as a result of your low antithrombin levels. And then obviously overt levels, AT deficiency is less than 70% of normal, a 3.48-fold increase, and that's an incredible increase in the risk of you having a VTE at some point in your lifetime. There's two types. The quantitative type, which is defined by low levels of AT activity and antigen, AT antigen in heterozygous state, and the complete absence of AT in the homozygous state. Unfortunately, that's not compatible with survival. Type 2, the qualitative defective binding domains for factor X, thrombin, heparin, or both AT activity and antigen levels are low to normal, and it's predominantly heterozygous. Functional ACTs are really the way to go. They're the most commonly used method to test for antithrombin 3 deficiencies or antithrombin 3 levels, period. The unfortunate part is antigenic AT assays are not widely used. They have a limited sensitivity and high specificity. So the primary or predominant source or predominant test for checking for AT assays would be the functional AT tests. Diagnosis of hereditary antithrombin deficiency. Patient history, as I said before, unexplained VTE at a younger age, less than 50, is significant. Recurrent spontaneous or unusually extensive spontaneous VTEs, unexplained arterial thromboembolism in a younger patient, unexplained VTEs at an unusual site, and recurrence of VTEs while adequately anticoagulated. And of course, a family history, family history of spontaneous VTEs, family history of known thrombophilia, even if the patient is asymptomatic. And even if one family member with a history of VTE, this may indicate that there is a significant risk for you to have this same deficiency. Diagnosis of how do we rule out acquired AT deficiency? Well, first of all, there's a lot of different routes, ways that people can have AT deficiency. One of them is drug-induced deficiency, so heparin therapy. You're going to become resistant to heparin over time, and this can drive down your AT levels. Consumption, extracorporeal cyst devices are notorious for chewing up AT3. Disseminated invascular clotting or coagulation, hemolytic uremic syndrome, decreased AT synthesis from liver disease, malnutrition, premature infancy, and of course, increased AT excretion comes as a result of inflammatory bowel disease and the nephrotic syndrome. How do we diagnose heparin or hereditary antithrombin deficiency? AT levels may be decreased during thrombotic event or heparin therapy. Vitamin K antagonist therapy may also increase AT levels, and the acquired AT deficiency should be ruled out before assessing for hereditary AT deficiency. Uncertain impact of new oral anticoagulants and laboratory assessments. And this is critical because there's a lot of things that people can purchase at your local GNC and all these other places, and some of these things we have no idea what they do. And it's really important to track back especially if you've had some kind of VTE or coagulation issue, you need to go back and look at all the supplements and all the other things that may be taken. And it's not uncommon for somebody undergoing surgery to be told not to take all these things for at least a week before they have their operation. So AT replacement may be needed when thrombotic risk is high. And when are the 3 times that they're the highest? Surgery. Surgery has a high risk for thrombosis, especially orthopedic surgery. Pregnancy, and there's a couple slides that I'm going to show you in a little bit, and they show the dramatic decrease that women have during their pregnancy with their AT3 levels. And then obviously VTE occurs in up to 85% of patients with hATd by the age of 50, and recurrent thrombosis occurs in 63% of the patients. So again, these are 3 areas that's very significant and very prone to thrombotic events and venous thrombotic events. Making the hATd connection. How do you recognize this patient as having hereditary antithrombin 3 deficiency? This is Stephen, 48 years old. Stephen's medical history includes recurrent DVTs. Recently, he was diagnosed with a DVT in his left leg and now has symptoms of recurrent DVT in his right leg. His family shows no obvious signs of thrombophilia, but there have been unexplained premature deaths on his mother's side. So there's the clue that something has been passed down through his pedigree tree. About 70% of patients with hereditary antithrombin 3 deficiency will have a thrombotic event before the age of 35. Now, here's Stephanie. This is Stephen's daughter. You know that Stephen has the trait. Stephanie's medical history includes pulmonary embolism, which occurred during pregnancy. She has 1 child and is considering having another. Her family history shows that her father has experienced recurrent DVTs, and clearly she's inherited that same trait. Up to 70% of pregnant women with hereditary antithrombin deficiency experience thromboembolic complications. Testing for AT deficiency, the perception versus reality. AT deficiency is rare, so there's no need to test. That's the perception. Reality is hATd may not be as rare as most clinicians believe. hATd prevalence in studies ranges from 1 in 500 to 1 in 5,000 based on the number sampling population. And of the estimated 547,596 patients hospitalized for VTE, each year in the US, 3% of those patients may have preventable events. Perception. Antithrombin levels don't matter to clinical management. The reality is the risk for VTE is high if hATd is not identified. It has one of the highest thrombotic risks of all inherited thrombophilias, and you saw that from the previous slide. And up to 70% of pregnant women with hATd who do not receive prophylaxis are at risk for thromboembolic complications. Low ET levels can cause poor response to heparin, and we're all very well aware of that. Hereditary AD deficiency, VTE risk, is it getting the attention it deserves? VTE risk in obstetrics. Thrombotic pulmonary embolism has consistently contributed to about 10% or more of pregnancy-related deaths in the United States from 1987 through 2009. Virchow's triad. What Virchow's triad is, it postulates the presence of 3 factors that predispose a person to develop vascular thrombosis. Now, in the pregnant woman, she has all of these traits: hypercoagulability, venous stasis, and vascular damage. All of these things occur in a patient with this disease. And the other thing that happens, venous dissension beginning at the first trimester, 50% reduction in flow in lower extremities. By the 3rd trimester, increase in clotting factors, as you can see from the little balance bar, some decrease, 10, 11, and 13 increase, and then you all have all these other factors that are increasing. All these happen in the pregnant woman. And nothing's more significant than this slide, which shows that as the pregnant woman approaches delivery, the AT3 levels precipitously drop, and they're at their lowest between about 0 and 2 days after birth, and then about the 3rd or 4th day, then they start to climb back up again. Again, risk of postpartum thrombotic events in a 5-year database in study shows that 0 to 6 days is the highest risk for a thrombotic event for someone with hereditary antithrombin deficiency. Up to 70% of women with hereditary antithrombin deficiency who do not receive prophylactic therapy will experience a thromboembolic complications. And during pregnancy, patients with hereditary antithrombin deficiency are at high risk for VTEs. This slide just shows pulmonary different areas of VTE, and this is some of the clinical pictures of what it looks like in somebody who's had this event. Pulmonary embolisms, again, account for nearly 10% of all deaths in hospitalized patients, making it one of the most common preventable in-hospital mortalities that is out there. And now, as I referenced before, surgery. General surgery has about a 25% chance of complications or VTEs. Oncologic surgery, 29%. Gynecology, urologic, 15 to 40%. However, orthopedic, 50 to 60%. I would find it hard-pressed if anybody's ever had any orthopedic surgery that they don't come out of the OR with the TED hose and those little pants that squeeze your legs, and there really is a big thing that to really try to prevent, especially in orthopedic surgery. And of course, total hip and knee replacement, it's a fairly significant number as well, partially due to inactivity after surgery, but certainly because of the gross manner that orthopedic surgery presents itself as. The risk of thrombosis or hemorrhage is especially high in patients with AT deficiency undergoing thoracic aortic surgery. There's a couple things going on here. Number one, how many of us cool a thoracic aortic patient down to 18 degrees? So the coagulation profile takes a hit with that alone, but let alone the magnitude of the surgery also presents these patients with a higher than normal complication rate with AT deficiency. Case studies, this is where it all wraps up pretty nicely. Body weight, this is Michael, 37-year-old male. Body weight, 98 kilos, BMI 34.6. He's got a medical history. He's failing bicuspid aortic valve, advancing aortic stenosis, mild left ventricular hypertrophy, prior VT events, AT deficiency, signal autosomal dominant copy of SERPINC gene 1, current complement, increasing dyspnea, on exertion, mild lower extremity, edema, and prolonged air travel or work days. Smoking status, he had a 30-year history, stopped 6 months ago. Of course, when everybody gets sick, they always stop. Nicotine gum is needed. Alcohol consumption, 2 to 3 drinks a day, and the patient does not want open surgery. He wants to have a TAVR. Pre-op clinical assessment, he's got a hardened left calf, obviously from the VTEs previous. Ultrasound revealed no acute DVT. Doppler color flow images shows 2 mild to moderate venous defects. Platelet count high, TG elevated, LDL-C elevated, D-dimer normal, AT levels 71% of normal, so right there you know he's got a low and he's at risk for an event. ACT is 140 seconds, but here's another clue. His PFA closed very early, so that would be suggestive of higher platelet activity when he was a neonate. Preoperative. Administers 10,000 units of antithrombin, 3,430 units, and ACT was 285 seconds after 10,000 units of heparin, and the AT of 3,430 units. Intraoperative, uneventful anesthesia induction, invasive monitoring, used TEE like all TAVRs, completely uneventful, and he had absolutely no issues. Additionally, dose AT post-op day 1 and started anticoagulation therapy on post-op day 2. Discharged, evaluation for addition anticoagulant, and follow-up scheduled with 3 to 6 months. Now here's a classic example of how a patient who knows they've got this defect can handle it, and it can be handled very routinely. On the contrary, Jessica is a 48-year-old female, body weight 68 kilos, severe degenerative disease in both hips, dependent on crutches, uses natural sedatives as a sleep aid, 2 miscarriages. She insists on having bilateral hip replacement in 1 procedure. Preoperative, CBC normal, everything's normal. Intraoperative, continuous subarachnoid block, placed uneventfully, right hip arthroplasty completed uneventfully. However, after turning to her left hip, the patient became agitated and short of breath and fell from normal to 89%. So things were starting to happen. Working diagnosis, pulmonary fat embolism from femoral canal. That's because of the orthopedic surgery. Evaluations, everything, the platelet counts were all normal, D-dimers elevated, TEG indicated maximal amplitude hypercoagulation state, and SaO2 further declined down 85%. So the initial interventions was increase O2 to 60%, and then start low dose IV heparin to balance risk of hemorrhage against ongoing pulmonary embolism. First bolus of heparin, 2,500 units, 104 seconds afterwards. No real response. Second bolus, 107 seconds. Third bolus, 114 seconds. The response, patient's fingers became dusky, suspect HIT or hATd. Failure ACT to respond with 3 boluses of heparin led to suspicion of alternative diagnosis. 500 units of antithrombin was administered. Now all of a sudden the ACT goes at 280 seconds. During the ICU, HIT antibody assay was negative, AT levels 65%. So there's the result of what her issues were. She didn't know this. And tissue and oxygenation gradually returned to normal. Post-discharge recovered, uneventfully completed this rehabilitation, aspirin 81 milligrams per day, 6 months of direct oral anticoagulants, and reevaluated for a lifetime for coagulation referral for full evaluation. Now this patient wears a medical ID bracelet indicating AT deficiency. Now you see the difference. There's one patient on one hand who knows they have this coagulation issue, and the second patient does not. So there's a big difference. So that's why it's important to look back at your family history, because it does have about a 50% chance of passing down through the family. And at that, I think I finished up right on time. Is there any questions? I think one of the most impressive things is the 2 case studies, and it shows that if you have it and you know it, it can be treated very simply, but if not, you can really run into a lot of trouble fast.
Tim Bazzelli from good, from Lynchburg, Virginia. So can I share a recent patient interaction that I had? So this patient with VV ECMO, can you hear me?
Yeah.
No, you can, okay. There's a VV ECMO patient on heparin. PTTs 50 to 60, had clotted off several circuits, was laying down thrombus, in the oxygenator, 3 o'clock, 9 o'clock, formed thrombin in the connectors, or horsetail hair, flailing stuff in the connectors also. So the PTT is 50 to 60. The AT3 levels were 50 to 60%. Corroborating ACT was 180. Or the 10As, 0.04. So can you put all that together and kind of explain what the discorrelation between the 10A and the PTT? Well, and with a AT3 level 50 to 60%.
Well, that's
0.04. PTT 50 to 60. I couldn't see if they had high elevated protein Cs and throwing anything off. But yeah, so can you put that together and see if what does that make any sense?
What was the end result of this patient?
Continuing on heparin, elevated occasionally, just continuing on, but there was still laying down clots in spite of the PTTs being within therapeutic levels. Continued to lay down clots, circuits changed, kept going on and on. So,
well, I think just for the mere fact, you said the AT levels were 60%?
50 to 60%.
That's low.
With the 10As, 0.04.
Right. So that's, I don't know the parameters behind the case that you do. If anybody else knows a pathway for that, I'd love to hear it. But in my opinion, or in my experience, the low AT3 levels are enough to cause all kinds of problems.
Even with a PTT 50 to 60.
Yep.
Yeah, that's what it was. Yeah. Okay, thank you.
Thank you.
Any other questions?
All right.
Hello. I was just curious, given the high risk of thrombosis in AT deficient pregnant patients, how common is testing for that in that population? And is there any like standards or guidelines for what would precipitate that testing?
Well, the standards and guidelines that would precipitate that testing is if there's a family history of any venothrombotic events or any coagulation issues, parents, things like that. But is there a typical test that people run on all pregnant women? No.
Is that something, are those questions that are being asked commonly, and even with those questions, is that specifically like those AT assays, are those something that's being
Well, one
run?
of the problems, we're in a world where everybody's trying to do everything cheaper. And if you recall back when we were doing cold agglutins, everybody was being tested for cold agglutins. When was the last time you heard of that being done? I mean, I don't know of it. I mean, there may be some institutions that do it, but where I'm at, I mean, we get around it we use 28-degree cardioplegia, so we don't have that much of a problem with it. Obviously, if we cool the patients, but like so many other things that are happening in the operating room, they're starting to whittle down tests and pre-op testing to absolute necessary, and things like AT3 levels. It's just not typically something that they're going to test for unless there's a family history. And that's why it's important to go back in your family tree to see if anybody's had this stuff, especially a pregnant woman. I mean, why not? It's worth looking into it, because that's going to be the best indicator, and that'll give you a 50% shot as whether you're going to have it or not. Because pregnant women, it's really significant the changes that their body goes through. It's a short period of time, but it really drops fast.
About 20 years ago, Bayer and the recombinant AT3 became available, and I was doing some work. We were using a lot of aprotein still. We were having a lot of clotting problems, you know, and we kept relooking at the aprotein and the renal issues. But to do an AT3 level at our institution, it had to be sent out. So to do it at the last minute when you already have a patient that maybe you can't get anticoagulant, it was just not the question. The cost of it was extremely expensive. Even back then, it was $1 per unit, international unit. So it was cost prohibitive. So the workaround was we couldn't get the test. When you were suspicious for it, the only thing you could do was order plasma, which would take anywhere from 45 minutes to an hour. So the way we justified the cost was the time you had to wait for the plasma to come up actually per minute at our hospital was $75 a minute. So I was able to justify the cost that we could actually keep AT3 in the refrigerator in the OR. So rather than test for it, if we were suspicious for it, we would give 1 amp, which is usually 500 to 600 units, which would usually get us to a safe ACT level. I then went to another hospital in 2008, and we kind of just went with that because we couldn't get it in-house, had to be sent out, and we currently keep at least 1 valve in the OR at all times. And if we can't give an additional heparin dose and get to that level quickly, we go ahead and give that dose before we go on.
You know, it's amazing how many things you can justify with OR time costs.
Yeah.
Because it's significant. And even, you know, let's say you got to give factor 7. I mean, we know how much that stuff costs. But if you think about how long that patient's going to sit in the OR, things start to balance out over time.
And the other end of it, we've seen a lot less bleeding post-op. We shared surgeons with somebody down the street, and they'd say, why don't you have as much bleeding as we do down the street? But we always had that available as an option if we couldn't.
So did you go through your transfusion committee with any of this, or?
No, at the time, there really wasn't even a transfusion committee. It was, this was very early on.
Well, now you would.
Yeah, now you definitely would because of the cost. But yeah,
right.
We had a fairly low blood usage anyhow. So
yeah, thank you for your comment.
I don't think it's published anywhere, but there is a direct correlation if you use the HMS with the candy stripe cartridge to a low slope on that cartridge.
Right. Yeah, heparin dose response curves. Right. That's one of the defensive mechanisms for doing that. If you do that dose response early on, you get a little bit of a hint as to whether you're going to have a problem with your ACT for AT3 levels. You think they're low AT3 levels.
Isaac from Johns Hopkins. Greg, the simple answer for all the 4 questions. Simple answer is I have answers for all those questions during my presentation today evening at 16:10. So that
Nice
is a
advertisement.
that is a simple answer. Brief answer is back to the ECMO question. ELSO recommends heparin concentration from 0.3 to 0.7 anti-10A, number 1. Number 2, AT3, if you don't have the AT3 adequately, it changes every 24 hours, and it changes significantly based on transfusions because it dilutes the AT3. Number 3, if you're having continuous ultrafiltration, Dalton, the molecular weight for AT3 is only 55,000 Daltons, so that it removes. So AT3 is the critical element that keeps your heparin functioning. So probably I would have gone, if that is the situation, I would have gone to the APTT recommendation by ELSO is 60 to 80 is the range. Maybe we can go a little bit higher. Number 2, give some AT3 to keep the patient is adequately anticoagulated. So that is brief answer to that question. Second question about someone made a statement, AT3 is more expensive than FFP. That is not true. FFP, when you're talking about the FFP, direct and indirect cost, Jeff Riley's publication in 2014, that describes FFP is more expensive than AT3 in a real world. Very brief answer this is, but I can explain those things during my presentation this evening. And what did you mention?
The HMS, Medtronic HMS.
Excellent. Yeah. HMS is the recommendation by the AMSECT, one of the tools we should use every perfusionist operating room to know the heparin concentration, patient-specific heparin concentration to be maintained during bypass. Resistance, heparin, AT3 deficiency, all those things are integral part of the perfusionist to maintain an adequate anticoagulation. Thank you.
Thank you, Isaac.
One more question?
Just a statement. He covered a lot of stuff to go over, but I was going to go along with her on the cartridge and we use a slope to get to AT3s all the time. Also, in 2006, there was a study done in cardiology. It's called the Horizon study. And they were looking at ways at that time to get people off of Plavix and use heparin. And so in that study, it was very interesting. They found that 75% of the patients, after being exposed to heparin 4 to 5 times, developed AT3 deficiencies for life. So we're seeing that now. I mean, I'm seeing a lot more AT3 deficiencies just because our patients are getting more heparin.
Yeah.
So that's all. Thank you.
Great.
Okay.
Thank
We
you.
have about 20 minutes of break time, if that's the last question. Oh,
And just to remind everybody that the BLS sessions are now open in the Blue Heron Room, which is around the back opposite the exhibition hall. And also in 20 minutes' time, Gabriella, if gives a wave at the back there, who is going to be our keynote speaker for this afternoon, is going to be first up. She's an amazing speaker, so please come back and be ready to answer some really interesting questions. Otherwise, thank you very much for another interesting session, and we'll speak to you later.
Thank you.